I can't really think of a better way to kick off Public Health Week. If you didn't know that, today is the first day of Public Health Week, and this is a fitting conversation to have where we will be honoring two of the leaders in public health, Martha Katz and Marshall Kreuter, and having as our special guest today, Helene Gayle. This effort is a third in a series and wouldn't be possible without the generous funding from the Healthcare Georgia Foundation, and you'll hear from Gary Nelson in a second. This is very important for us at the School of Public Health because health disparities are really central to our mission, and our research and teaching and what we do as a school really is focused on reducing health disparities and looking at health equity and how that can be improved. We're really honored to have Helene Gayle here to share her insights onto health equity and her experience during her career, which you can read in your program, and wanted to make sure that I didn't repeat now because it would take half the time to recite Helene's accomplishments. Our careers have crossed many times. Most recently, Helene was the CEO of CARE, again, right around the corner from here. And I was looking at the vision statement for CARE, and it is to seek a world of hope, tolerance, and social justice where poverty has been overcome and people live in dignity and security. For about 10 years, Helene led that effort, and CARE is a major partner in the public health environment in Atlanta, making Atlanta really, we think, the public health capital for the world. Before leading the effort at CARE, Helene spent time at the CDC and also with the Bill and Melinda Gates Foundation, and served as Assistant Surgeon General in the Public Health Service. You can read in the brochure her countless accomplishments and awards. I believe, 13 honorary degrees, which is, I'm not sure it's a record, but it's quite impressive. And today, Helene recently left Atlanta to return to DC, where she's heading up the McKinsey Social Innovation Institute. I probably got that wrong. And you might want to think of changing the name to Social.
We probably will.
Social Innovation.
I can't say it either.
It kind of rolls off the tongue. I like that. So, in any case, let me ask Gary Nelson to come up and introduce our named individuals for this lecture series. Gary?
Sure. Thank you, Michael, and good afternoon, everyone. As many of you may know who've attended this event in the past, we began the lecture, or now a conversation, with a video, and the rumor has it that our namesakes, Marsh and Martha, have taken that video, so we have no opportunity to shine a light on the many accomplishments. So I have the honor and privilege of describing for you, or reporting for you, the many things that they have accomplished in their public health careers. As I've said in the past, at the intersection of issues of social justice, effective health policy, and evidence-based programs that improve the health of underserved individuals and communities, you will find the inspirational leadership of Marshall Kreuter and Martha Katz. Their professional careers epitomize that ancient proverb that says, "We are all better because of leadership, who plant trees in whose shade they know they never will sit, always paying forward." They have left an indelible mark on academia, and yes, their scholarly work is highly respected, but their mentorship of students and faculty and their flair for teaching has been exemplary. A legion of students owe them a debt of gratitude. Throughout their careers, individually and collectively, Martha and Marsh elevated the credibility and impact of countless professional organizations, bringing discipline, direction, and thought leadership, keeping public and private, national, state, or local organizations on course. Guided by a moral compass, an ethical compass, and armed with data, Martha and Marsh's footprint is visible in policy and advocacy, both locally and nationally. They have incubated a number of organizations and advocacy efforts that have become the champions for issues of health equity, from tobacco to health coverage to obesity. They have engineered for many of us a culture that values results, measurable outcomes, never compromising on accountability and transparency, and insisting on applicability and utility. Like the School of Public Health and its focus on urban health disparities, those of us in philanthropy have benefited from their compassion for marginalized populations. They have led as comfortably and as effectively from the back as they have from the front. Frequently by choice, they have been out of view, but never far from impact. So from a perspective of academia, governmental public health, and philanthropy, their contributions are many. And for this foundation, at the core of our mission of Healthcare Georgia Foundation is a deep belief in health equity. It guides the work we do in communities we serve, and it guides the people we engage with. It's why we do what we do, which also happens to be a publication that Martha co-authored for us. And some 15 years ago, I'm not so sure that many foundations beyond ours had claimed health disparities as a funding priority. So we at the foundation are so very pleased to be able to sponsor this lecture and conversation in tribute to my close friends and colleagues who have been so instrumental in the success of my own organization and in pushing the public health agenda forward through their years of service in both the public and private sectors. And finally, I can think of no one more qualified to represent this issue than our guest, Dr. Helene Gayle. Thank you.
Okay, can people hear me? I can't tell from down here. Is there a way to, there we go. Thank you all for coming this afternoon. We have a game plan. Marshall and I have pulled together 5 sets of questions for Helene. As you hear us ask those questions, you will hear some of your questions in them. With us, let me try and see if I can make this louder. How about that?
Put it in your neck.
Is that better?
Put it on your neck.
Try that.
How about that now? I'm going to hold this sucker. There we go. New approach. Forget about clipping it. Okay, here's the game plan again. We've got 5 sets of questions. As you can imagine, we've had many a car ride having a conversation about what questions we wanted to ask Helene. So we've been working on these. But last week, all of you were asked to submit questions. And we took a look at those, and what you're going to hear is some of your questions interspersed with ours. And we'll let you know when it's one of the fabulous questions we got from one of the students at GSU. So, with much, and then we're going to leave some time at the end so that those of you sitting in the room and some of you who are in distant places, if you wish to share them electronically, we will have microphones down the middle, and we will give you an opportunity to ask Helene some questions yourselves. So here we go. Ready?
Yeah.
They're going to be easier to hear than I am. Helene, I just loved listening once again to your fabulous resume of experience, because we've had the pleasure of watching you do what you do. From your early career at CDC to your work at the Gates Foundation to your leadership at CARE and now at McKinsey, you've had a fabulous career and you've made a huge impact which has been recognized, and one of the reasons we're so thrilled you're here today. But as I would be one of the students sitting in the audience, I would want to think, how does all of this fit together? It's sort of an atypical career path. What could I learn from that? How does it work for you, and how could it work for some of the students?
Great. Well, thanks. And before I answer that, let me first of all just say how honored I am to be part of this and part of this series. It's named for the 2 of you who have, as you said, been part of my career since the very, very beginning. I also want to thank Michael for your kind introduction. but also for the leadership that you have given as the inaugural dean here and all that you've done to build this up. I must say, I too have problems with McKinsey Social Initiative, and that's actually my email, Helene@McKinseySocialInitiative.org. And there's so many I's in initiative that I'm always misspelling my own email address. So it's okay. It's not. It doesn't roll off your tongue. We'll probably change that at some point. But let me to your question. I really feel fortunate. I do feel like I've had an incredible career. None of it planned. And one of the questions I'm asked so often when I talk to young people is, so what was your 5-year plan? What was your 10-year plan? How did you, figure all this out? And I was like, I've never had a plan. But, I guess what I did have was a guiding philosophy. And, I went to medical school partly because medicine was fascinating and, I did well in science. But I really went to medical school because I wanted to have a career that I felt gave me something tangible that I could give back. And, medicine is obviously in health is really a cornerstone in many ways. But as I was going through my medical training, I realized that so much of what I was seeing in the clinical setting were people coming in and out for the same thing over and over again. And if I wanted to have an impact at a broad level, I could probably do that by doing something beyond clinical practice. And we often say clinical practice, the patient is the individual is your patient. And when you think about public health, your patient is a community, a society, a nation, or a world. And so, I came to CDC, met many of you people here in this room, and really fell in love. I came to CDC for the EIS program, thought I would stay for 2 years and then go back either to clinical practice as a pediatrician or do something else, and stayed for essentially 20 years. And, I was fortunate to be asked to go to the Gates Foundation and start what at that time was the very early days of their global health work. And it was funny, again, a CDC connection, because Bill Foege had gone there to help them get started in global health. And, I thought I was at the center of the universe, CDC, the government, and he started talking to me about this Bill and Melinda Gates Foundation. I kind of got that Bill Gates was an important person in the world, but I don't think I really got it. We used Windows and all that sort of stuff. I got that, this computer thing and this Gates guy must be important. But then I, realized after talking to him a while what an incredible opportunity it would be to be at the forefront of this, what, was clearly going to be an important institution. I went to Gates, and I think it was a wonderful opportunity to open new worlds. Having spent all of my career in government, I knew the public sector. But at the Gates Foundation, it really is a foundation created by two business people, really in many ways at the juncture of how you can use the private sector and business approaches to have a social impact. And so it opened up a whole new world for me in terms of understanding other worlds than I did at CDC. Then I get a call about care, and very different job, very different organization. It's a global poverty organization. Well, I'd been doing global health, thought of myself as a health person, but then started realizing if I wanted to have an impact on health in a broad way, a lot of the things that influence people's health have less to do with medical or health interventions. They have to do with issues like whether or not people have access to clean water, whether they have an income, whether they have access to education, whether women have a chance to have a voice in their families and in their communities. And so for me, it was in a way coming full circle. The very reason that I wanted to go into medicine, which was to have a chance to have a huge impact on societies, was what brought me to care. And the ability to work on the very things that we talk about as the determinants of health, as well as the direct health interventions, was kind of for me, in many ways, a dream come true.
So what would you describe as one of your greatest challenges?
time management. Probably one of everybody's greatest challenges. I think, so I'll talk about some of the things. CARE in some ways was my largest stretch organization, stretch job. First time I'd been the head of an organization, a CEO. As many people know, CARE is a large global organization. We operate in about 80 countries around the world, 10,000 staff. A not-for-profit organization that lives off of other people's money. It was the first time that I had to go from being, as people say, on the other side of the paycheck. I'd always been either a government funder or a private foundation funder. So going to a job where I had to raise resources was a huge challenge. And we went through, like so many not-for-profits, went through a period when the economy was tanking and we were losing a lot of our financial base. Government funds, which CARE gets a lot of USAID grants, were drying up, as well as just private contributions. And it was the first time in my life that I had to go through a restructuring or laying off staff. Huge, huge challenge. And when you know, all of us who work for organizations where people come to work every day because of their passion for the mission, because they are committed, and you know, it's an organization that had people who had been there decades and decades. Their families had grown up around CARE, and to have to look in people's eyes and tell them that they no longer had a job was a real challenge. On the other hand, we all know when you're running an organization that if you want to fulfill the mission of that organization, it has to be financially viable. And so, tough choices though they were, at the end of the day, it was in service of our mission. And it's what's always kind of, when I've had to make tough choices, it's what's always what keeps me able to move forward, is that you realize you got to make tough decisions in order to actually do what you're trying to accomplish. And sometimes in the short run, it doesn't feel very good, but in the long run, you're actually serving your mission.
Now, Marshall has some of the student questions.
Yes, I have a student question for you, and here's what one of them asked. Sometimes we learn more from our failures than our successes. Would you share an example of a failure for which you are grateful?
Well, we could be here all day. Yeah, I'll give a funny one that's maybe illustrative of a broader principle. So I had to do, as many people do when you're representing organizations, and this was back when I was at CDC and I was heading the work in HIV, and I did a lot of speaking in a variety of different organizations. And for me, it's always easier to speak to people who are professionals who you can speak about data, and you can show PowerPoints and speak about facts. But this was a speech that I had to do at a community-based event, and it was at a Baptist church. And how many of you all have ever been to a Baptist church, kind of know how Baptist preachers talk and the cadence that they use and, you know, the drama and all the rest of it? So I said, okay, I'm here at this, Baptist church community event. I'm going to try to, be like a Baptist preacher. And so I start my talk out in this kind of trying to do this cadence, And I start 5 minutes into it, I'm like, you sound so stupid. And I just said, okay, I'm going to stop trying to be something that I'm not, and I'm just going to speak like I speak. And I say that, it's kind of a funny example, and but it really is about authenticity and how you can make sure that you're being your own authentic self. And it was just one of those reminders that when you try to be somebody who you are not, at the end of the day, it doesn't serve you well. And okay, I don't have the flair of a Baptist preacher, but I had something to say. And I think people appreciated what I had to say when I stopped trying to be somebody that I wasn't. And I just think, for me, that's one of those lessons that I learn over and over again, that no matter what, if you can be who you are and tap into that, that always serves you a lot better than trying to be somebody else.
Okay, here are two interesting questions from the same student. I'll read them both and you can respond accordingly. What advice do you have for young women who seek positions of leadership in their careers? And as a female CEO, do you face struggles in a world dominated by male executives?
Yeah, well, it's a great topic, and again, so many of these questions are lectures or talks in and of themselves. And I think the whole issue, and it's coming more and more, whether it's Sheryl Sandberg and Lean In, or Anne Marie Slaughter, who wrote the "You Can't Have It All," and everybody's talking about the whole issue of how women juggle the variety of things that they juggle. And clearly, in the work that I did over the last 30-some years in the global arena, you see it even more, how challenging it is for women to break through and juggle a variety of different lives. And I'll just give it's a little bit off, but a little bit parenthetical, but it gives an example of how extreme things are in places around the world. I remember going to visit one of our projects in a country in East Africa, and I was meeting with our staff, and a woman came up to me afterwards, and she said, we really are so excited. I was the first woman CEO of CARE, and she said, it's so exciting to have a woman at the helm of this organization. How did you get here? And so I went through, not dissimilar from what I said before, how my career had evolved and what I had done and all the rest of that. And she pulled me, and she said, that was the question in the group. And then afterwards, she came up to me and she said, no, really, how did you get here? And essentially, did I have to sleep with a lot of men in order to get to where I was? Because the only way in her society a woman would have been in that position would have been to have made some pretty severe compromises. So I just say that to say, relatively speaking, I've had it easy. But I never forget the fact that around the world, there are women who face really even more severe challenges just trying to hold jobs and to have leadership careers. I guess, I feel fortunate that in some ways, being in the environments that I've been in, where, in the government, we have rules against anti-discrimination. We have, clearly, in the social sector, I think people are more aware of these issues, and you tend to have people who are more sensitive to that. That said, I think I have had the same sorts of situations like everyone else. I don't know how many times I sit in a room, say something, my male colleague next to me says the same thing, they get recognized, I don't. Even as the CEO of an organization, my people who answered and reported to me would sit in meetings, they'd get acknowledged, I wouldn't. And I think you just, for me, I continue to try to use examples as teaching examples, because mostly people don't do these things out of malice. They do things because of unconscious bias, which we know exists in our societies. And unless we're constantly trying to bring to attention in real time, you did this, it made me feel like that, and the light bulbs go off. And so I guess it's an added burden that we carry, but I think unless we continue to realize that most people don't do things out of malice, they do things out of lack of understanding and awareness, and if we can continue to build those bridges to awareness, I think we will continue to make progress for women in the workplace. That said, I think we need to make sure that we have more women in the workplace, because ultimately, without critical mass, we continue to fight the same battles. And study after study shows that somewhere around a third is this magical critical mass where women are able to have an influence on their organizations in ways that they couldn't if they weren't there, and if they were there in smaller numbers. So I think numbers do matter.
Thank you. Those of you who know Marsh Kreuter know that he has an extraordinary passion for communities and community engagement. So no surprise, he's got some questions about that.
This is theme 2 of our discussion, and it's called Engaging Communities in Public Health Problems. So I'll try to be brief in reading this and then pose the question. It's 2016, and in some parts of the world, we still don't understand the leading causes of death. Less than a year ago, a friend of yours and former CDC Director Jeffrey Copeland, who now heads up the Global Health Institute at Emory University, received a major grant from the Gates Foundation, you're familiar with them, to answer the epidemiologic question, what are the leading causes of mortality for 0 to 5-year-olds living in low-income sub-Saharan African countries? Now, to scientifically answer that question, the study requires minimally invasive postmortem autopsies within 24 hours of death to get that information. Because of the wide ranges of cultural, spiritual, and economic differences in those countries, Dr. Copeland and his colleagues were keenly aware that even a minimally invasive procedure like the one I just described was likely to be resisted by residents. Thus, one of the central questions was, what strategies should we undertake to encourage families who have just lost a child to participate in that program? Now, while that may seem to those in the audience as a rather dramatic example, social and cultural complexities continue to be barriers to improving health globally and in the United States as well. So, here's the question. Based on your experiences, what are your thoughts on possible approaches to addressing social, cultural, and economic dimensions of complex health challenges like the one I just described?
Well, I guess I would have called Dr. Copeland in and have him answer it for me. What did you do? No. Yeah, I guess I'll answer it somewhat simply and incompletely, because I think there is no exact answer, and it's a challenge. I think we face it, as you mentioned, here as well as around the world. But I think, first and foremost, I think it is always important to ask ourselves, is the data that we want actually important, or is it a must-have, or is it a nice-to-have? And and not making any judgment about this particular study, but I know so often we go into communities and we've got the ideal of all the data that we want to collect, and sometimes it's not actually necessary. It's feeding our own curiosity, and you could actually get the answer simply in different ways. That aside, because there are often times where, in fact, the information is critical. And I think that having communities involved is the answer for me in so many ways. Even in the design of the study, making sure that communities are involved so that they can help inform and feel like they are a part of it. It slows studies down, it makes it a lot more complicated, but I think the more we actually do studies with the community as part of it and co-owning it, it makes it different, it helps. May not have helped in this situation, very challenging, touching on cultural beliefs and cultural norms. The other thing is, though, I think is continuing to make sure that community leaders are role models. And I've been in many situations where, just to back up, even in this country, autopsies are not well accepted in many communities. And it wasn't until people in those communities with information and with incentives started understanding why autopsies may make a difference, and then role modeled and said, okay, I'm willing to get an autopsy on my family, and then talk to 10 other people. And so I think ultimately it is, how do you engage people in the communities themselves? And I often say I think we do a better job internationally than we do here in our own country. And oftentimes, it's the norm in international settings to make sure that we're involving communities, because we're going in and we may not be of those cultures, and we need to have people who are from those cultures to help inform it. I think we don't do as good a job here, and it's part of why I think we continue to have some of the persistent challenges of health and health disparities, because we're not involving the very communities who are experiencing the health disparities. So for me, ultimately, the bottom line is, how are you involving communities all along in the process so that they feel like they're partners and they're actually co-creating? That said, there are always going to be these really difficult challenges where where sometimes it is figuring out how do you back from what is ideal and look at what do you do that could in some ways give you answers that may not be as complete as you want, but at least are getting you part of the way there.
That response actually leads into this next question, because it comes from students that are related to the same subject. And it is, how can public, and it also is effective to Georgia State University, how can public health training institutions help their graduates prepare for and address those very real complexities that you just mentioned?
Yeah, I'll go back to the answer that I gave about women and how important it is to have the numbers of women increase if we're going to make a difference for women in the workplace. And I think it's the same for communities that we want to make a difference in. I think it is important, and I think this is an institution that reflects it. It's a very heterogeneous institution. And I think it is increasingly engaging people who come from the communities that we're working with. But I think until you have people who represent communities at risk, communities where we know we're facing health disparities, I don't think we're going to be able to answer the problem, because my experience is my experience. Your experience is your experience. We are all better at coming up with solutions about things that we know something about. And so I think, unless we have the right people at the table, we're not going to come up with the right solutions.
Okay.
So let's shift.
And unless we listen to them, which is another real issue. I think we bring people to the table, but want them to come up with the answers we want them to. And all of this is about, how do we give up power, and how comfortable are we with sharing power, and the uncomfortableness it is with getting an answer we didn't expect.
Perhaps you should share that with the United States Congress.
Oh, well, yeah.
That's
I'm realistic about what I can take on in life.
So while we're at the community level, let's talk about social determinants of health a little bit. Last year at this lecture, Jim Marks talked about RWJ, Robert Wood Johnson Foundation's efforts to build a culture of health. And when you look at what they're doing, they're working on a broader set of issues: healthy housing, early childhood, bringing in new characters to the table, from lawyers to the YMCAs, the food banks, the Federal Reserve. When we look back at what you did at CARE's very much looking at those broader social issues and economic development issues. So from your experience there, how do we bring some of that back to the public health field? And what are some of the lessons from your work there that you would share for both domestic and global health work?
Yeah, thanks. And one of the things I've always said, and kind of alluded to it in one of my other answers, I just wish we did more interface between global and domestic, because I just think there's so many lessons to be learned. And I think we have tended, and it's changing, but I think we've tended to do one direction and not bi-directional exchange. And so there's always been, we're going with our information and our knowledge, and I think more and more. And again, I think there are a lot of people in the room who have done a lot of that, bringing some of those lessons back. So just, as an example at CARE, one of the projects that I really loved was our Village Savings and Loans project. And it's a fairly simple methodology. People save pennies. It's a method of microfinance, but it's not one that depends on taking out credit. It's kind of like, analogous to how we all first learned about money. We went and had our piggy banks and we saved first before we went and took out a loan. So this is kind of community savings. People take their pennies and put them together and then give loans to each other. And it's a way that particularly very, very poor rural women who don't have access to financial institutions are able to amass some resources that then allow them to do things like start businesses, send their children to school, or in many cases are able to access health care that they never would before. So one of the projects was one that was particularly women saving so that they were able to then afford prenatal care, and if they had difficult birth, emergency obstetrical care. So it's things like that, knowing that people have the ability to have the economic power to actually access services. We also did a lot of work with agriculture and nutrition. In many ways, and I was at the Division of Nutrition as an EIS officer, we have nutrition that sits in health, and then we have agriculture that sits in development or an agriculture department, and the two often don't come together. But obviously, having adequate food has something to do with agriculture, and having good nutrition and the two go hand in hand. So we did a lot of work with women farmers and looking at making sure that their crop choices were the kinds of crop choices that actually added to good, healthy nutrition for them and their families. And so I think it's mixing those sort of things. I happen to sit on a panel for the Institute of Medicine that the Robert Wood Johnson Foundation is funding all around community interventions for addressing health disparities. And one of the really exciting things is that most of what we're listening and people who were coming in and speakers are from housing, transportation, education, and very little health interventions, really looking at, so how do we do a better job of bringing all these other areas that, again, have so much more to do with the root causes of poor health and really getting them into the mix.
Very much the new frontier of public health.
Yeah, very much.
So the students are very interested in the work you did at CARE with women and girls, and particularly the education of girls. Could you talk about that for a few minutes?
Yeah, well, it was one of the reasons I was so excited about coming to CARE at the time that I came, because I'd worked in HIV for decades, and particularly working in HIV globally, you realize that although HIV is in some ways an equal opportunity virus, it does disproportionately impact some people more than others. And in Africa and Asia and around the world where it's primarily heterosexually transmitted, women are disproportionately impacted because of their social status. It's not yes, young women, some of that's biologic, but so much of it has to do with the fact that women don't have the power to negotiate safer sex in many places around the world. So, it was one of the things that made me very, very heightened to this whole notion that women and women's status around the world has as much to do with the poor conditions that they find themselves in. And right at the time that I was coming to CARE, which started as giving out care packages after World War II and doing a lot of emergency work and all the rest, was really moving to thinking about what is it going to take, and what are some of the ways that you can have a huge impact on reducing global poverty. And if you look at all the statistics, girls and women make up the largest proportion of those who live in poverty, make up the largest proportion of people who are illiterate, work 2/3 of the work hours but only get 10% of the world's income, and on and on and on. And you can go through the statistics, and clearly if you want to have it as an epidemiologist, if you want to have an impact on where the problem is greatest, you would go to women and girls. But that's kind of the numbers part of it. But the opportunity part is that all the data also suggests that if you can invest in a girl or woman, you have returns that go well beyond that individual. So a woman who is educated, is able to earn an income, is more likely to put that income into her family, send her children to school, and then you have this kind of virtuous cycle that starts to break away and chip away at the cycle of poverty. So, I was excited to come to CARE at the time that we started the I Am Powerful campaign and really talking about how do you empower girls and women. Education was one, access to finances. I mentioned some of our work in micro finance, working with women farmers. Around the world, women do most of the farming, but get the least amount of farm inputs and access to information and access to capital to actually increase their productivity. So we really, looked at across the board, all the work that we did, how do we make sure that we invest in girls and women, because then you have this multiplier effect that goes well beyond just those individuals.
Now,
I also wanted to mention, and I have here, was also when I went to McKinsey, they had just put out this report called The Power of Parity, Advancing Women's Equality globally, and this is in the United States. And the report is really fascinating because they took the economic aspect of it and kind of took the economic lens, and I won't go into the whole report, there's a few here if anybody's interested, but it showed that if you could increase women's parity in workplace participation, the full-time, part-time mix, because more women work part-time, more men work full-time, and the job mix, so in other words, women going more into the more lucrative roles at the same level that men did, you could increase the world's GDP by $27 trillion. That's pretty amazing. I mean, just by unleashing the power of women. And in the United States, you could increase by 4.3 trillion, I think the number is, which is a 9% GDP increase, just if you look at parity of women in those three different ways. So, it's huge. I mean, unleashing women's power is the answer.
I'm going to leave now.
Including for our congressional problems. But anyway.
so one of the fun things about living with Marsh Kreuter is that he wakes up in the morning with an idea. Not 1 day a week, but 7 days a week. So one of the ideas that he asked me about one day is, how do you market health equity?
So that's the theme for health equity. Just a quick question. How many in this room, how many people have ever heard of the term health equity? Would you raise your hand? Seriously, stretch it up if you raise your hand. Put it down. How many have not heard of health equity? Okay, all right, good, very good. Now, with those people, how many in this room think that health equity is a good idea? You stretch it up a little bit? Okay, all right, good. So this is what this is about. Throughout our careers, and many in this, particularly those up here, global policies and U.S. policies on health have focused, not using the term, on health equity. Let me share a couple with you. In 1974, Mark Lalonde and his colleagues in Canada put out a document called A New Perspective on the Health of Canadians. And that, according to many people, led to Surgeon General's report on health promotion and disease prevention in 1979, and then the documents Healthy People, 1990, Healthy People 2000, Healthy People 2010, Healthy People 2020. All of those documents emphasizing equity. And the World Health Organization's Health for All initiative, that was also focused on health equity. And of course, the current Affordable Care Act focuses also on health equity. Now, while a majority of people in this audience would be supportive of the notion of health equity, a recent survey and what we see, unfortunately, in the political arena suggests that that's not the case for many people outside this room. It's not unusual to hear people say something like this. Look, I've worked hard all my whole life to get where the hell I am. Working and earning a living, that's at the core of our country. That's what I was taught, and I work hard. Just think of what will happen if we give free health care to those who don't work. Look, I don't want a giveaway system like that. Do you? So now the question is, how do we market health equity to people outside of this room so they will want to achieve as much as the folks in this room want to achieve?
Yeah, well, and I know there are a lot of great marketing people in this room, so I'd love to hear other people's answers. But I guess partly it's our notion of health as health care. And, health equity goes far beyond health care. And, I think, there's a lot of, obviously, a lot of different opinions about how do we have access to health care, and I'll talk about that in a minute. But when I step back, I think a lot more about what does it take to actually be healthy, and what does it mean to have environments where people have access to adequate but good nutrition, places to exercise, access to enough information, and all the, could go on and on and on, but all the other things that we know really make up what it means to be a healthy individual. And I don't think there's too many people who would argue that, in fact, having people be able to be healthy, be able to raise their children, earn an income, and all those things really do matter. But I think we do need to change our notion that all of us who are in public health know that health goes well beyond access to health and health care. But I also think, we do live in a country that doesn't think of health or health care as a right. And in most countries around the world, the notion that health and health care is a right is pretty fundamental. And so I think there is a conversation that we need to have in this country that gets people much more comfortable with the notion that just like we feel that all citizens should have the right to an education, that it's a public good, and that it isn't something that you work hard for and deserve. It's a public good. But I just think it is definitely a different notion, and something that we need to have a much broader conversation around.
And one way we might expand that broad conversation is maybe to call attention to the health officer from DeKalb County, Sandra Ford, who is sitting right here. It's hard to talk about health equity in other countries. So the question is, what's your experience in DeKalb County, and how might we learn from that experience?
So, no pressure. I knew lunch was going to come at a cost, right? So, health equity at the local level, and I'm glad, Dr. Gayle, that you made a distinction. There's a difference between access and literacy and equity. And so a lot of what we focus on in DeKalb, particularly because if you don't know DeKalb, it is one of the most diverse populations in the southeastern United States. On any given day, there's between 130 different languages and dialects spoken in DeKalb. So me giving you an insurance card and sending you to a doctor that does not speak Farsi or Urdu, I'm still not helping you. Or if I hand you a prescription assuming that I put it in Spanish because I know that you speak Spanish, but you're not literate in Spanish, then I'm still not doing what I'm supposed to do. So it's about equity, which means everybody has the same opportunity to get good health. What we do in DeKalb is focus on a lot of different types of things. One of the big things in the southeastern United States I find is that we talked about this at lunch, a very different dietary inclination, I'll say. You all in your sweet tea, I'm still trying to understand that whole concept. But I was surprised to learn that we still have food deserts in DeKalb County, which I consider a relatively urban area. And there are areas in this county where you have to drive a considerable distance to access fresh fruits and vegetables, which is to me like a right, like clean water. And coming from California, where you can literally almost reach out of your window and pull out an orange or an apple, it's a big deal to not have that. And so we've been working with partners to put mobile fruit markets throughout the county. We're working very closely on school-based health. It still stuns me how we're fighting with the academic institutions to just allow the kids to have physical activity in school, not understanding that kids that come to school well-nourished and with opportunities to move around are more successful academically. We're not partnering enough to have true health equity. We have a history of putting out a really strong status of health report in the county every 5 years. And we spend a lot of time trying to figure out how we're going to roll this out and who's important to have this information. But this year, the 2015 health report, the first people we're going to start with is the Chamber of Commerce. We're going to roll it out to the business community, because when you're trying to sell an industry, one of the first things people ask about are, what are schools like? You know, what is insurance here like? And you can't have a successful, booming economy without a healthy population. And so when you talk about equity, all those things have to be considered. In terms of a marketing of equity, it's that win-win. When we talk about infectious diseases, for example, you can't go to a movie theater and worry about who's sitting next to you. It really is irrelevant. If they have active TB and they're coughing, you're going to get it. It doesn't matter what their socioeconomic status or where their zip code is. If you're sitting next to them, you're at risk. And so for health equity, we have to let people understand the win for everyone, because when you're talking about disease, it doesn't respect your wallet and your car you drive and things along that line. And so it's a real basic understanding of, if I'm better, you're better.
Thank you very
And I
much.
think it's making people understand what public health and prevention actually do. And I think to your point about infectious diseases, you know, trying to get people to understand why it matters that, you know, you have clean water, and that those things don't happen by accident. And I think we don't fully appreciate kind of the infrastructure that we take for granted that is part of all of us having the opportunity to have a healthy lifestyle.
The folks in Michigan know that.
Yeah, well, yeah, right.
So now we're ready to begin some audience participation here. Last week, our 15-year-old grandson, Oscar, was with us. Mm-hmm. And like most people his age, and I would bet 99.9% of the people in this room, he has a smartphone and he has it in his hand a lot. So his grandfather asked him, how often do you use that as a telephone? And he said, well, it probably rings twice a day, once from my mom and maybe from you. How often do you use it for texting? Probably 200 times a day, says the 15-year-old.
Yeah.
So we went and looked at the data. We thought, oh, well, we're pretty sure he's normal. And it turns out that of the 7 billion people in this country, we have more than 7 billion cell phones going around the world. I mean, sorry, billion in the world,
yeah.
Excuse me, in the world. And that it turns out to be one of those equalizers, that it's widely used by African American youth and equally used by Hispanic youth. So here's our question. How do we use it more for public health purposes? There's some research going on about that, but it's still a new horizon. So those of you who've been thinking about the future, how do we use the mobile phone and mobile technology to be mHealth?
So that's our question to you.
And we have
We have a
microphones.
hand, yes.
There could be a job that you can there for you.
Come to a microphone.
Actually, come to the first one. There is none.
And introduce
Somebody took the one back there, I think.
Okay. I am Dr. Angelica Jeter of Morehouse School of Medicine and the Satcher Health Leadership Institute. And Dr. Satcher told me to tell you hello. So to answer your question, it brings this project that I'm working on, well, we're still working on it, with Dr. Laura Salazar, and thinking about ways to possibly implement an intervention, an HIV prevention intervention via text message. There's a lot of research being done on that, but it's very possible to engage and get girls and boys engaged to lead through peers, connect to peers by sending out messages, sending out health information, and getting them involved. So there are ways to do it, but the key is to find who are the leaders, who has the network, and to develop the programs. So we need more money to be able to do those programs. One of the questions that I had for Dr. Helene Gayle is, a lot of my work focuses on sex trafficking prevention, especially here in the state of Georgia. So what is something that we can do to help engage and empower young girls to keep them from being trafficked, but to also support survivors?
Yeah, let me go back to the question about the SMS as well, and then I'll get to that. Couple of examples, because I think it is, in some ways, one of those things that can revolutionize health and health access. And in some of the work that I was doing at CARE, we did, using cell phones, enabled women who were in rural areas or healthcare workers in rural areas to be able to get information and send information. So imagine a woman in a rural village being taken care of by a health worker who only has a certain amount of training. She was able to get information on complications, and if a woman went into complications of labor, she was able to send messages on to the next level of health care. They would then tell her, what she could do in that environment. If she continued to have complications, they could SMS ahead and send her on. They were prepared for that person. And so, by having the ability to send information back and forth, it definitely allows people to have access who wouldn't have access, otherwise. Ebola in Nigeria, one of the reasons they were able to stop Ebola cold was that they had an SMS system that they had developed for polio. So that if you saw a case of polio in the efforts for polio eradication, if you saw a case of something that looked like polio, you could easily just SMS into the health system, the public health system, and then they would know where they needed to go. The same thing with Ebola. If you saw somebody who you thought had signs or symptoms of Ebola, they could then radio in, and they were also able to, because they had this whole network out, send SMS to the whole population essentially. Here are the signs and symptoms of Ebola. If you see anybody like this, or if you have these symptoms yourself, get to the nearest health facility. And that's why, one of the largest, the largest nation in Africa that was able to stop Ebola in its tracks just using the whole SMS system. So, I mean, it has huge applications, and particularly when we think about how do you have greater access in places that don't have, the same sort of access that we take for granted. Oh, so your sex trafficking. Yeah, that's a challenging question. I think, first of all, giving young women options. And at the end of the day, for so many of these issues, people get trapped, and particularly women and girls get trapped in situations because they don't have options. They don't have access to education. They don't have access to incomes. They get into situations because they don't have a way of making livelihood. They get sold into by accident often to things because they think that they're going to be able to get an actual job and not. So a lot of it is really just about how do you give options and making sure that there are safety nets there for young women who are vulnerable at risk, and doing a better job of that. I don't think there's one simple answer, though.
Gentleman had a question. Yes, sir.
I'm a physician at Emory. We had a high school student who just recently took a book that we did that's been translated in a lot of different languages that 150 doctors helped write on symptoms that are life-threatening, so somebody knows when to go to the emergency room. I don't know how many people here would know if you had a headache and a fever and couldn't put your chin on your chest, how many of you would go to the emergency room? Yeah, if you ask a lot of physicians, they know that can be meningitis. And empowering patients, I think, is a very, very important way to help patients. We also had a book, Your Body's, Let's Play Doctor. And you could teach people via a website how to look in eyes, listen to hearts, which a doctor can do. And at Emory, we actually had students learn that. Some of them went on to medical school, and the deans called me and asked how come they already knew how to do it. But I think empowering patients can be a very, very powerful vehicle to improve healthcare. In a developing country, when we had a humanitarian summit at Emory, there was a doctor who came and went on these Christian missions to Africa and taught teenagers how to do C-sections and gave them the supplies so they could do it, so the baby didn't die in the mother's uterus.
Thank you. Yes, ma'am.
My name is Elizabeth Ophelia. I'm from Morehouse School of Medicine in Atlanta. Thank you all very much. So I just wanted to ask the question around the extremes of life, which is where our healthcare expends a lot of resources right now. And coming back to the discussion around health and not healthcare, what is our opportunity to look at that lens in terms of this notion of the how do you convince people about health equity? Because I think when you think about children and the opportunity with children on the one hand, and then the elderly, this is where everybody sees, everybody would agree. But on the other hand, our current health insurance system tends to be in the middle. So, you know, when we're all active and working, that's when you have the best options. And at the extremes, you know, you have to be really poor or to get the broader access to prevention. So I don't know if you're catching the question in that. I'm just curious as to maybe changing the script a little bit and asking about these vulnerability at the ends, the beginning, and not necessarily the end, but the other side.
Senior side.
Yeah, and thanks for your question and also a lot of the work that you do in the community. I'm not sure if I have a good answer to that, and there may be others who have thought more about it. I guess I just think, you know, we aren't very holistic in the way that we think about health more generally, and particularly, again, health versus health care. You know, we all know the statistics, and I can't quote them off the top of my head, but we spend a huge amount of our health care dollars in the last years of life, disproportionately so. And we don't do such a good job of how do we make sure that people stay healthy and looking at the early through middle ages of life. And I just think we need to think more about that and, you know, how are we valuing life? How are we thinking about making sure that we're allowing everybody to have equal access, but also equal opportunity to health more broadly. Because I think we have a very skewed healthcare system when we think about how our dollars are spent. And when we think about how little goes into prevention, how little goes into the things that really that affect a greater proportion of health and health outcomes, they aren't where we're spending our money. They're not where we're putting our research dollars. And you know, for so many of us who spent so many of our years in public health and CDC, and when we look at the CDC budget, for instance, compared to what other federal more care-related agencies got, we just start, you know, and you know it from the DeKalb County Health Department. We just are not really good about thinking what truly will make the greatest difference for health and putting our dollars there. So it doesn't exactly answer your longevity and the ends of the spectrum, but you know, I think just more broadly, we need to think about where do our dollars go and how can they have the greatest impact. And you know, the WHO did a great study that showed that the United States spends more money than almost any other nation in the world, and we're way down into the wrong in terms of our actual health outcomes. And so we've got a real mismatch between dollars and what we get for those dollars and what does it mean about the health of our population more broadly. And that's what I think we have to start grappling with.
Actually, we have time for just one quick question. As one of these hands from a student will be biased towards students here. Short question, and it'll be a short answer.
Yes.
Hi, my name is Jeremiah Williams, and I am an MPH candidate at here, Georgia State. Yeah. So, I recently read a statement in the American Public Health Association, in a report from the American Public Health Association, and So I recently came across this report, and I saw this statement, and it resonated with me. Here we go. If we want to get to a place of health equity, we have to dismantle the systems that are preventing communities from reaching their full potential. This means examining how our systems perpetuate inequality. In your opinion and experiences, what systems specifically perpetuate inequality here in the U.S.?
Yeah, okay, that's a deep one to end on. Yeah, well, I think broadly speaking, inequality breeds inequality. So, we know that we have systems that keep some populations, that limits the option and potential of some populations more than others. I think things like racism play a huge part, and the fact that we have, systemic racism in our country, and that people of color are disproportionately impacted when you think about health outcomes. So, I mean, that's just one example, but I think all of the things that we think about that lead to inequality in our country, whether, income inequality and all that goes with that, those are the same systems that lead to unequal health outcomes. And I think until we attack those and attack them openly, honestly, and with courage, we're not going to change. And I think we're fooling ourselves if we think that we can do this in a cosmetic way. It really does take having some bold, honest, open, direct conversations about these structures that, go beyond an individual's ability to change their own outcomes. And we could name them, but I think that's what it's going to take. And that's again why I love the work that Robert Wood Johnson is doing around culture of health, because they really are looking at how do you honestly look at the underlying causes of poor health. And it goes well beyond who has an insurance card or not. It goes to the points that you were talking about. Do you have access to high quality foods? Do you have food deserts or not? Do you have access to enough education so you can start shifting to patterns of diet that are more healthy? Do you have schools where they have physical education any longer? So I think all of those are the kinds of things that we have to start attacking if we're going to change the issue of health inequality.
I'd like to add one point. Don't ever forget the question you just asked.
And keep asking yourself that.
Well, thank you.
So let me, as we wrap up, let me just make a couple of comments. Who in the audience thinks that Marshall and Martha should have their own TV show? Okay. Secondly, join me in thanking Helene for very candid and personal and thoughtful remarks. We have a small token of our appreciation for Helene for your coming back to Atlanta and speaking at Georgia State. Yes, you can.
Okay, thank you.
And I'll just...
Martha and Marsh's name on here.
There you go. In my remarks to introduce Helene, Marsh, stay seated for a sec. Marsh. Sit down. Come on, give me a break. No. So my introduction for Helene, one of the remarks said that Helene is one of the most powerful and successful women leaders in the United States. So the first thing I did was cross out women. And just Helene is clearly a national and international leader in public health and health equity, and we're really delighted for you to be here and are excited about the future of what happens next. I want to wrap up by acknowledging, again, thanking Gary and the Georgia Healthcare Foundation for their sponsorship of the Kreuter and Katz conversation, and to acknowledge we have a committee to select the speakers, and I'd like Linda Kay McGowan and Larry Green and Ginny Bales just to stand up and to thank you for your So we have some of the best minds to select the best speakers for this series. This is our third. And let me conclude by simply saying we hope you'll join us next year for the 4th annual Kreuter Katz Conversation. And I'm pleased to announce that next year's speaker will be Matthew Kreuter, the son of Marshall and Martha. Which they didn't know yet, so this is a bit of a surprise for Amy and for Martha and Marshall. And Matthew is the Associate Dean of Public Health at Wash University in St. Louis, and a well-regarded scholar on health communications, and particularly in how to communicate to disadvantaged communities in a way that gets appropriate health behaviors put in place. And he has a book coming out on health communication research. So with that, thank you all for joining us. We have reception out there with light refreshments, and we'll look forward to seeing you all next year, probably during Public Health Week, once again. So thank you.